I would say that 3/4 of the world still isn't getting this right and hasn't really figured out a way to manage patients with metastatic castrate-resistant disease to the best of their abilities with the resources available to them. We have one ARS, I think, so we'll go ahead and do that. A 48-year-old man with a rising PSA despite a castrate level of testosterone presents for evaluation of possible treatment. Staging workup reveals no radiographic evidence of metastases. In this scenario, FDA-approved agents for the management include, and they're listed there. So, which agent is approved in that clinical scenario? So 77% got it right as we speak today, and so we're going to talk a little bit about that. There are currently no approved agents for the M0 space. My goal is just to talk to you about why urology should be managing these patients and how to kind of incorporate that multidisciplinary care plan, think about ways to do that in your own practice, review some of the evidence-based therapeutics, try not to overlap, like I'll not talk about bone health that much because that was covered well a little while ago. So my number one message to you is that I think urologists should be a primary caregiver for men with prostate cancer as it relates to that. This includes as they progress through those roller coaster disease spectrums that you've seen on some slides to come and many in the past. A patient may progress through his disease, but he shouldn't have to progress through multiple providers and specialists. And so I think we provide a constant to the patient in their life. It's a real disturbing thing when you have been seeing a patient from diagnosis through treatments and all of a sudden you tell them you're not going to see him anymore. They know something's really wrong. I think the psychological burden of that alone is a problem. But we understand the progression of their disease. We understand the management options, hopefully, of patients as they progress through those various diseases, and we can coordinate the specialty care that they need from other specialists to treat their cancer as well as lots of ancillary help. So that's what I'm going to try to outline. We need to establish and organize and manage the multidisciplinary care model that incorporates available resources and works best for your healthcare environment. There's not one size that fits all. So you have to figure out what it is you have available to you and how you can best make that fit. Now, there's been a lot done on this multidisciplinary care, and urology is late to the table for this, really. But due to all the excitement around therapeutics that we have, the increased need to help manage these patients, we know that patients benefit from this, not only from their psyche and just an overall emotional benefit, but there's good data from other cancers where they show better outcomes related to the coordination of care and the better management that happens when experts get together and discuss the options for these patients. So this is a theoretical model that we published, but the concept is there, and you have to, again, kind of figure out how does this work for me when I go home. But the ingredients are the urologists, the medical oncologists, radiation oncology, and supportive services. And those supportive services should not be underestimated. Those include navigators or assistants. They can be nurses, they can be PSR, they can be lots of things, but they have to be smart enough to know what is the patient going to need and how do we maximize the visit. Tumor boards or discussions about what next for the patient, how does the patient present, what other imaging or testing does he need. Clinical trials feed right into this, and we wouldn't have good news to spread in a couple of weeks, and all of the FDA approvals came from clinical trials. And so while we're not curing cancer, we are helping people and extending the quality of their life and the extent of their life. We hope to do better in the future, and if we don't have that coordinated care where we can identify patients for these trials, we won't be able to move the needle forward. So I think all those ingredients go together. Now, if you were a patient, you would want the one-stop shop, right? All in one. You go to the large group practice, you go to the center, you go to the cancer center, the hospital. You're going to see the people you need to see that day. You're going to block out some time, and you're going to get as much done in that one period as you can. That is really advantageous for the patient, but not always advantageous for the provider. So that's where that navigation and coordination of care comes in. You don't want to be sitting in your office while they're only seeing med-onc or radiation oncology and vice versa. So it has to be worked out so everybody stays busy, and it's an efficient way for you and the patient to be seen. However, we know that one size fits all doesn't work, and there may not be that option for you available. Patient may not be able to see medical oncology because they don't have clinic on the same day you do, or maybe physically you're not located in the same location. So the concept, though, would continue in an alternative model, which could be, a different day if you have to, or it could be same day, different clinic. And I'll just breeze through that, but it doesn't really matter. I mean, it's optimal if you can do it all close in proximity, et cetera. But the ingredients have to be there if it can't be done on the same day. And that means communication between providers, some way to, share in the patient, whether it's a virtual tumor board or a real tumor board. Those conversations have to take place in order to maximize the outcome for the patient. So again, the ingredients are listed here. I know that, many of you who do these know the importance of the navigation. Nurse practitioners and physician assistants cannot be overestimated in this situation. Meetings, depends on how availability, how often, but more is better than few. If possible, a shared EMR. And one of the biggest barriers we have is collating and accumulating all the information that comes across the fax machine. So it lends itself to larger centers or shared EMR if possible. Primary care. Now, medical oncology may be comfortable managing some of the hypertension and some of the other things that come up, but having a primary care engaged and knowing that they're receiving the information that you're doing is also very helpful, along with supportive services. And that could be nutritionists, it could be pain management, certainly palliative care when it's required. So all that stuff has to be known, available to you, and you have to be anticipating how you're going to get them to those next steps. The next step is, if you've developed this system for managing them, how are you going to deliver the treatments and the therapeutics and organizing your thoughts around the sequencing? There are lots of guidelines out there. They really speak the same language. So you just have to figure out which one is user-friendly for you. And that's what we tried to do with the AUA guidelines, is make them algorithmic or simple, because there isn't really guidance on where it's appropriate, which one should go first. So that's going to be left to interpretation of the treating physician. But the reality is these things are evidence-based. Some have a little bit more to them than others. I'm partial to the AUA guidelines because I think that they were truly evidence-based, but they're in constant need of revising, and this year will be no example. Dr. Crawford showed this a little bit earlier, and this is that roller coaster slide, which patients don't like because it's an uphill battle for them as they progress through these various treatments. But when you have all these different treatments available to you, you have to think in your mind, okay, where is the patient in the journey? Are they hormone naive, or have they ever seen these type of treatments? Are they castrate or endocrine resistant? Do they have metastatic disease or not? And then what are the treatment options available to them? There are many treatment options available. The skeletal-related bone health agents were mentioned earlier. Of course, those reduce risks of skeletal-related events and can improve on things, but they have not extended life. We have certain treatments that are available for pain management, including some of the radionuclide therapies that were talked about before, except radium, which does extend the life. And then you have these survival improving treatments, which are chemotherapies, androgen access, as well as the nuclide therapy of radium. So all of those are important. They're all options on the menu. In 2004, docetaxel got approved and things started to happen. Then was a drought. About 7 years later, a second-line chemotherapy. And then we started filling in the blanks with some oral agents that were approved post-chemotherapy, followed by agents that were the same agents tried in a pre-chemotherapy setting. Radium came along, CYP-T came along, but we have been a little bit in a drought for a couple of years while we wait for the next step. And while Lenny Gamella said it's the year of the Eagles, we'll wait and see about that. I think it's the year of the M0, because now we're going to start seeing some activity in a space where we've had no treatments before. So I'm excited about that. When we made these guidelines, developed them based on partly the way that the guidelines, but the FDA approved these agents, and partly based on the clinical recognition that the presence or absence of metastatic disease was important. The degree and severity of their symptoms was important. Performance status was critical. We can't give these drugs to everybody. And again, in the beginning, when drugs were being approved, prior docetaxel was sort of mandated to get the ball rolling, and that has changed a lot over the years. So there were 6 index patients, and those are there for you to read. This M0 patient, which was the ARS question, is the unmet need, and 75% of you already knew that we have nothing really approved in this space yet. So things get done for these patients, but they're really just kind of manipulating the PSA a little bit, and they're not really extending their life or really changing anything. So we're excited about this, and this will be updated as soon as the data comes forward. We think in a couple of weeks we'll get the presentations. The publication should come pretty quickly thereafter, and then we'll be in business. For the most common patient who has early metastatic CRPC, those with asymptomatic or minimal symptoms, we have a lot of options. So there's abiraterone with prednisone, there's enzalutamide, there's docetaxel, we can give CYP-T. So all of those are options for those patients. And if you've been doing some of the things that we've talked about, like Dr. Crawford was mentioning, really monitoring those patients to see where they're at, you'll catch them before symptoms are plaguing them and they lose their eligibility for some of these treatments. I'll just briefly say that the Cougar 302 trial was the second trial for abiraterone plus prednisone, and it did demonstrate not only a survival advantage as well as a progression-free survival advantage in patients with metastatic castrate-resistant disease prior to chemotherapy. The enzalutamide PREVAIL trial similarly was the second big study for them, and it was compared enzalutamide to placebo, again showing significant survival advantage and radiographic progression-free survival in men prior to use of docetaxel. So these were game changers really, because before these 2 trials came out, we waited until they progressed through docetaxel to even begin to give them their treatment. Docetaxel was the original chemotherapy that showed benefit in survival. It was a every 3-week regimen, and it was compared to weekly, and it was compared to mitoxantrone. And I think sometimes we forget that. It wasn't compared to placebo, it wasn't compared to water, because when you look at the overall survival, you see there is benefit, and it translated only into, on average, somewhere around 3 to 4 months. But what would have happened if they had received no chemotherapy, and what would have happened if they would have received the chemotherapy earlier? Those are questions we're starting to understand now that docetaxel is being used in a more earlier stage in the hormone-sensitive area. The use of immune-based therapy, the only immune-based therapy approved for prostate cancer, CYP-T, with its IMPACT trial, was a significant improvement. They were a little narrow in their approval, so it's really reserved for those minimally symptomatic and asymptomatic patients. And so in that group, there was a significant survival benefit, and so that's where it's used. But once they determine that they're having symptoms, especially enough for narcotics, it's really hard. And we're fighting an insurance battle as I speak, because a patient was taking some narcotics for his knee. Had nothing to do with his cancer, but they saw it, and they don't want him to get approved for the CYP-T we've already administered. So we're having to go back and explain to them, this narcotic wasn't for his cancer, but it's an uphill battle when you have that happen. Index patients 3 were those patients with symptoms. Usually in the studies, they were, it was described as pain, but there are many symptoms of metastatic disease. And in there, the same options exist, with the exception of CYP-T, which drops off when they're symptomatic. And then additionally, radium-223 is an option for these patients who have bone lesions, no visceral metastases, and it's approved both in the pre-chemotherapy as well as in the post-chemotherapy space. Lenny showed the study earlier, so I don't have to really go over it, except to say that it was best standard of care compared to radium, best standard of care, survival benefit, first time seen using radionuclide. All the other stuff we had before was toxic and palliative, and so this was an advance forward. Index patients 5s are the patients who have seen prior docetaxel chemotherapy, and many of the patients that we're going to see going forward will have seen docetaxel before. Cabazitaxel is a salvage regimen. Some people are using it up front, and maybe Dr. Petrolak will talk about that, but it got approval as a second-line therapy in that setting with, again, significant survival advantage compared to mitoxantrone post-docetaxel. So it is an option. And then, as I mentioned earlier, abiraterone, enzalutamide, as well as radium plus cabazitaxel are all options for men who have been through and progressed through the docetaxel. Future directions are really the M0 space, and that's where we're headed. And so I hope next year when we're at this meeting, we'll have lots of good stuff to show you. But right now, these are the trials. So most of us are aware that enzalutamide has a trial looking at the M0 space called PROSPER, and it randomized those men with no radiographic evidence. And the outcome that they're looking for here is metastatic free survival. So that's an important thing, different than overall survival, which was the approval for most of the other drugs that we looked at. There's another agent, ODM-201, the Aramis trial, which also is in that same space, similarly designed, placebo versus the agent, gaming for metastatic-free survival. And then finally, there's a third one out there, ARN-509, the Spartan trial. So 3 agents all going after that same patient population, all with that metastatic-free survival endpoint, along with secondary endpoints. But it'll be, way too soon to see any overall survival. So the spectrum of disease is shown here, and unfortunately for patients, they don't like it. The treatments are moving back, so we started with end-stage, post-docetaxel, pre-docetaxel. Now we're moving into the M0. We've already moved on the other side of the equator when patients present with newly diagnosed metastatic disease. And so when the guidelines get revised by the AUA, there is a bigger move afoot to do more of an advanced prostate cancer guidelines now that we have good data from Stampede, Charted, Latitude, in addition to these new agents in the M0 space. So I think 2018 will be a banner year again for improving the outcome for patients with metastatic castrate-resistant disease. I think that our goal here is to try and make sure that as many as we can of the urology large groups, small groups, academic, private, that they understand these treatments, and we're really the messengers and the primary caretakers of these patients. So in conclusion, urologists should be the primary caregivers for these men with advanced prostate cancer. Establishing multidisciplinary clinic is an important component to this, and you have to cobble together the resources that are available to you based on your own situation. We have lots of good therapeutics in an area where we had no therapeutics before, and lots of things to offer patients. Do they cure them? No. But will they help them? Yes. And when you're in that situation, you're going to want somebody to help you too, and these are important advancements for them. And so the guidelines are going to be updated. NCCN, I'm sure, the AUA guidelines for sure, and we hope that they'll be more robust than what we were able to do the first couple of times based on what was out there. So I finished a little on time, which is not a problem around here, and I thank you for your attention.